You are welcome to this lecture series, and the topic for discussion this session is ectopic pregnancy. I'm Professor Abiodun Peter Aboyeji, Professor of Obstetrics and Gynecology of the University of Ilorin. And at the end of the session, I expect you to know what is ectopic pregnancy. So we talk about incidence and definition, etiological risk factors, pathology, clinical presentation, investigation, and management. Ectopic pregnancy is derived from the Greek word called ectopos, that is out of place. And it's one of the most common gynecological emergencies and is responsible for significant maternal morbidity and mortality. Following an ectopic pregnancy, chance of subsequent successful pregnancies is reduced. In simple terms, it is just the implantation of fertilized ovum outside the uterine endometrium and complicates about 0.25% to 1.5% of all pregnancy. Incidence varies between geographical regions for many reasons, one of which is the fact that we do not know the actual pregnancy that occurs in the population. And other reasons that different denominators are used in calculating the incidences. However, it is important to know that incidence of ectopic pregnancy is on the increase. And some of the factors that may be responsible for this increase are: one, the greater prevalence of STD, especially chlamydia infections, development of newer diagnostic tools with improved accuracy, tubal factor infertility, and increase of assisted reproductive techniques. What are the risk factors? The risk factor of ectopic pregnancy remains enigmatic, but the common denominator in most of the theories is the fact that there is delay in ovum stroke blastocyst transport. We all know that the myoelectric activity of the tubal wall propels the ovum from the ovary into the from the fallopian tube into the uterine wall, endometrium. Whereas when it is fertilized, it needs to. So anything that affects the myoelectric activity of the tubal wall may cause a delay, and therefore the developing blastocyst may become big and get implanted. Also, some of the estrogen, progesterone. We know that estrogen increases the tubal wall motility, and progesterone actually decreases it. And we also know that estrogen increases development of cilia, whereas progesterone decreases cause an atrophy of the cilium of the epithelium. So all these factors may cause a decrease in the delay in the transport of ovum, of fertilized ovum, from the fimbrial end of the fallopian tube into the uterine cavity. However, we can know some risk factors. Some of the high risk factors include tubal corrective surgery, tubal sterilization, previous ectopic pregnancy where the patient has another 10 to 20% of risk of recurrence, patients who have been exposed to death in utero, current IUD users. We know that IUD are supposed to prevent both intrauterine and extrauterine, but they protect more of intrauterine than extrauterine. Previous history of pelvic inflammatory disease increases the risk of tubal ectopic pregnancy. If we have one episode of PID, you have a 13% increase or risk. If it's two episodes, there are 35% increase of risk of ectopic pregnancy, and if you have 3 episodes of PID, it increase about 79% risk of tubal ectopic pregnancy. Other risk factors include infertility, previous genital infection like post-abortus or puerperal sepsis, multiple partners, salpingitis, nodosa. These are just diagnosed by an histological evidence of tubal ischemic diverticular. Other risk factors include the previous pelvic or abdominal surgery, smoking, and douching. Now, we talk about pathology. First, we look at what are the possible sites of ectopic pregnancy. The tubal ectopic pregnancy is the commonest, account for about 95 to 98% of all ectopic pregnancy. And on the tube, the ampullar region is the commonest, and then followed by the ischemic and then the interstitial. We can also have fimbrial ectopics. Those are the ectopic on the fallopian tube. We can also have include ovary, the cesarean section scar ectopic, abdominal pregnancy, and cervical pregnancy. For the greater part of this lecture, we shall be talking more of tuber ectopic pregnancy because it's commonest. But we'll still create time to talk about the other non-tuber ectopics like ovarian pregnancy, cervical pregnancy, abdominal pregnancy, and cesarean section scar pregnancy. Now, what I let's now consider the tuber pregnancy. Now, in tuber pregnancy, what is the natural progression of ectopic pregnancy for tuber pregnancy? It can be a ruptured tuber pregnancy. It can rupture at any time. Of course, the pregnancy can get spontaneous involution. The conception dies very early without any notable symptoms. There could be complete tuber miscarriage as in normal intrauterine pregnancy. We can have incomplete miscarriage too, as in intrauterine pregnancy, and then we could have what we call tuber mole or caneosma, where there's a seducer bleeding around the dead fetus and will not be recognized until it drops off or discovered during laparotomy for other reason. Now, I was talking about the time of rupture. The smaller the length, the caliber of the tube where the thing is implanted, the earlier the rupture will occur. So in ischemic ectopic, probably rupture between 6 and 8 weeks of gestation. In the ampullary, because the ampullary is disability distensible, it ruptures with about 8 to 12 weeks, and it is the commonest of all the tuber pregnancy, that ampullary rupture, which accounts for about 80% of all tuber pregnancy. Interstitial, whereby there are a lot of muscles, it may take up to 12 weeks because there's a lot of muscle around the corner end of the uterus, and therefore it enlarges before it ruptures around 12 to 14 weeks of pregnancy. And it is a highly vascularized area, and then as we'll see later, it causes a lot of major obstetric hemorrhage, and the patient can actually present in shock or even fainting attack. Now, I would like to mention right from there are some histological changes that may be found when you perhaps do curating of the suspected ectopic pregnancy. It's not usually done, but of course, it's important for us to know this. That's what we call ariacellular phenomenon, and it consists of hyperplasia of glandular cells, closely packed cells, large irregular hyperchromatic nuclei, cytoplasmic fasciculation, loss of cellular polarity. So this finding is not specific to ectopic pregnancy, but of course, taking in conjunction with other findings, it may help in arriving at a certain diagnosis. Now, what are the clinical presentation? I've said earlier in a pathology that ectopic pregnancy and tuber ectopic may be on rupture. In other words, there may be no symptoms or rupture. The rupture is perhaps more common out of the two. And of the classical triad of common tuber rupture are the abdominal pain, amenorrhea, and abnormal vaginal bleeding. These occur in about 50% of the patient. It is rather important to know that abdominal pain is the most common complaint. The pain could be localized or generalized depending on the volume of blood that is in the peritoneal cavity. So you may have a general abdominal pain, localized in the lower abdomen, depending on, like I said, on the volume of blood that has been lost into the abdominal cavity. Other times, going to be shoulder tip pain because of the irritation of the phrenic nerve that supplies the diaphragm. So that will cause shoulder tip pain. Other symptoms could be vomiting, dizziness, fainting and fainting as well as syncopal attack, and shock. Particularly the rent in the tuber wall leads to a massive hemorrhage. So the patient can come in shock, and then rather than the other complaints. When you examine a patient, it's important for us to know that what you find depends on the amount of blood that has been lost into the peritoneal cavity. First, there may be pallor of varying degrees, from mild to moderate to severe pallor. The extreme may be cold and clammy because of the collapse in the cardiovascular system. There will be bradycardia, tachypnea. Again, the finding depends on the amount of blood that is lost into the peritoneal cavity. The pulse could be rapid and trailed. Of course, sometimes you may not be able to determine the blood pressure, that may be hypotension. When you examine the abdomen, again, there will be abdominal distension of varying degree, like I said earlier, because it depends on the amount of blood that is lost into the peritoneal cavity. So it might be just a superbly fullness or a full abdominal tenderness. and then local tenderness and general abdominal tenderness. The tenderness is right iliac fossa, and then there will be rebound tenderness. Sometimes blood may collect in the pouch of Douglas, and for that, when you do a cholecentis, as you see later, we may be able to find aspirate blood non-clotting from the pouch of Douglas. When we do vaginal examination, you might be spotting per vagina, maybe frank bleeding, and when you do go on to do continue, you might be cervical external tenderness, and then administer fully and tender. You will be very careful when you examine a suspected case of ectopic pregnancy, not to exert much pressure, because an ruptured ectopic can be converted into full-blown rupture if it exerts too much pressure on when we are doing our next examination. It is important for us to mention at this stage that presentation can be acute, subacute, or acute on subacute. Acute in the sense that when the rent in the fallopian tube leads to massive bleeding in the peritoneal cavity, patient may present with fainting attack, shock, fast threading pulse, and so on and so forth, and greatly distended abdomen. In that case, the diagnosis is very easy. In the subacute variety, the blood loss is small at a time, and therefore, when there's a small rent in the fallopian tube, and there is blood loss in small quantity into the peritoneal cavity, that may elicit some fainting attack, mild abdominal pain, which will disappear. And of course, the patient may have repeated vaginal bleeding. It is therefore important for when they are taking history, they want to be sure when was the last normal menstrual period. Because sometimes patients may think that, because I bled 2 or 3 days ago, that was probably her last menstrual period. But of course, like I've just said, in subacute, patients may present with regular vaginal bleeding as a result of the pseudo that is being shed from the uterine cavity, and therefore may not come with the frank usual fainting attack and shock. So it is in subacute variety that you have to heighten our index of suspicion in any woman of reproductive age who complain of abdominal pain and amenorrhea, and some abdominal pain and amenorrhea, so that because of the fact that the blood loss at the time in the peritoneal cavity may not be massive, they may not faint, they may not come in shock, but they may have amenorrhea, abdominal pain, and then a slight dark vaginal bleeding, which may be recurrent. So that's the fact that the subacute sometimes prevent the diagnosis challenge unless you heighten our index of suspicion. Now, on the acute, on subacute, there is baseline subacute, but sometimes the rent in the tubal wall becomes, maybe just by one reason or another, becomes large, and massive bleeding now follows on somebody who has been complaining of irregular vaginal bleeding, fainting, and that come and go, and therefore we now convert from subacute into an acute. Again, on all these 2 cases, we must heighten index of suspicion so that we will not miss cases of ectopic pregnancy. Well, what are the differential diagnoses of ectopic pregnancy? We include threatened miscarriage, incomplete miscarriage, septic abortion. Gynecological causes include pelvic inflammatory disease, rupture or hemorrhagic corpus luteum, salpingitis, tubo-ovarian torsion, degenerative fibroid, endometriosis. Any pain, anything that can cause pain in the lower abdomen, appendicitis, diverticulitis, urinary calculi, urinary tract infection, gastroenteritis, because sometimes a pregnant can be presented with with diarrhea, and then perforated pelvic ulcer disease because of the abdominal pain. Now, again, I've said earlier that most of our discussion will be on the tubal rupture. Now, if the patient comes with tubal rupture, they make your clinical diagnosis. What do? We must do some investigation. And of course, the common one we need to look at the hemogram, look at the hemoglobin concentration, or pack cell volume. You group and cross-match the patient, and then you do resource typing. One important thing we need to do is beta ACG. It's a glycoprotein that is useful in the diagnosis and monitoring of treatment of ectopic pregnancy. It is important for us to recognize that the doubling time of beta ACG is between 2 to 2.7 days in the first 35 to 42 days of pregnancy. They are important in the monitoring. It's getting important for us to know that increase in beta ACG less than 60% over 48 hours is suggestive of ectopic pregnancy. If there's a plateauing of ECG, in other words, the doubling time is more than 7 days and above, again, this is suggestive of ectopic pregnancy. So, beta ACG occupies a central role in the diagnosis and management of ectopic pregnancy. Other thing you need to do is serum progesterone that is not still as useful as beta ACG, but of course, level that is less than 20 milligram per ml indicate abnormal pregnancy. Level greater than 60 milligram per ml is in keeping with normal intrauterine pregnancy, whereas value between 20 to 60 milligram per ml is equivocal. So it is not as useful as beta ACG, but we can use it as part of adjunct in making a diagnosis and following up with the patient. Now, if a patient comes with massive bleeding, typical of rupture, acute rupture, ultrasound may not be necessary. But of course, in the subacute variety or acute on subacute, abdominal ultrasound and transvaginal ultrasound are very useful. Now, particularly, like I said, in the subacute, whereby the patient may have this recurrent abdominal pain, recurrent vaginal bleeding. Therefore, if you are able to get in conjunction with ACG measurement, you look at what we call discriminating zone of ACG. So value of ACG between 1,500 and 2,000 international per liter. If you do a transvaginal scan, one should be able to pick intrauterine pregnancy. Whereas for transabdominal scan, value of ACG more than 6,500 unit, international unit. If you do a transabdominal scan, also we do pick the intrauterine pregnancy. So if you have such cases and you're unable to pick the intrauterine pregnancy either with the transvaginal scan or the transabdominal scan, then ectopic pregnancy is highly is suggestive. Now, if you have a negative ultrasound finding with value below all these discrimination zones, like I said, we suggest an early intrauterine pregnancy, non-viable pregnancy, or an ectopic pregnancy. So sometimes all these scenarios may create what they call a term pregnancy of unknown location. Laparoscopy, actually, in the past used to be the gold standard, but nowadays with the less invasive use of transvaginal scan, it's not the gold standard because it's an invasive procedure. So, with advent of ultrasound, both the transvaginal scan, but diagnostic laparoscopy has a place because if you are not sure, you can look into the abdominal cavity, particularly if you have the experience, but could be useful in suspected cases. If for one reason or another I don't have ultrasound, which I think is not likely in this nowadays. But diagnostic laparoscopy is actually useful in again making a diagnosis of tubal ectopic pregnancy, particularly on rupture one. Dilation and crater, where it's no longer done per se, but remember I told you about the areocellular phenomenon. If you do dilation and crater, you'll be able to see the historical feature we described for areocellular phenomenon, which is again one must emphasize is not specific to ectopic pregnancy. Cholecenthesis, we know, I said earlier that we can aspirate blood, non-clotting blood from the posterior fornix of the vagina. Again, may be useful if perhaps you don't have facility for ultrasound, you have facility for laparoscopy and so on and so forth. So if somebody comes in complaining, and strongly believe it is ectopic pregnancy, cholecenthesis, which you have leads to withdrawal of non-clotting blood. Colon flow Doppler, again, could be used because, if you have your susceptible ectopic pregnancy, we subject it to ultrasound, there will be vascularity around the adnexal mass, which may be useful, to you. Taking in conjunction with other history, and then that investigation will help you to know that you are dealing with ectopic pregnancy. I must emphasize again, in acute rupture ectopic pregnancies, some of these tests are not necessary because somebody come in collapse with amenorrhea, with a bloated abdomen, with general tender abdomen, the diagnosis is clear, it's clinical, and therefore one may not necessarily resort to most of these diagnostic tools. But all these become very useful, particularly in subacute, which may pose diagnostic challenge, and sometimes in acute and subacute, which may pose some diagnostic challenge. Now, we now look about management. Again, you must know that management depends on the presentation. Is it acute? Is it ruptured or not ruptured? And desire for future fertility. We will discuss first on the unruptured ectopic pregnancy. But of course, like I said, you must take whether you are dealing with unruptured or ruptured, You must take you must resuscitate the patient, particularly if they are in shock. You must establish an intravenous line. You have taken your blood group and cross-matching. You have taken a Paxil volume, and then you cancel the patient on treatment options, because that is very important. You must cancel your patient on treatment options that are available, having done your general physical examination, abdominal exam, pelvic examination. So the treatment option could be expectant, what we call control expectant, and then medical or surgical. Again, it's important for us to mention right from the start that, again, it could be conservative. In other words, you want to conserve the tubes. That's why I said, desire for future fertility, you might want to conserve the tube, or you want to remove the tube. So the conservative, again, could be medical or surgical. Medical says that you can use drug. Surgical, you can use laparoscopy. And sometimes, again, if you don't have facility for laparoscopy, and then you don't want to use the drugs, you can do laparotomy too. So that's why I say that the treatment could be conservative, whereby you want to conserve the tubes, or radical remove the tube. We will discuss about the controlled expectant management. These are for unruptured tuber ectopic. So this is for unruptured tuber ectopic. And what are the criteria? Of course, the patient should be asymptomatic. That patient the ectopic is not ruptured. The patient should be hemodynamically stable. The hemoperitoneum should be less than 100 ml. Of course, in the canal, you need for us to use ultrasound, be able to measure the hemoperitoneum. The ACG level should be less than 1,000 international by liter at the initial presentation. The adnexal mass should be less than 3 centimeters. And there has been objective evidence of resolution. In other words, there declining beta ACG level on monitoring. Now, once ACG occupies a central role in the management of ectopic for diagnosis and for monitoring. Now, patient must be fully aware. That's how I say you must tell the patient that and be fully compliant and must be willing to accept the potential risk of tuber rupture. That patient should be under our care in the hospital. It's not the kind of patient you send away because it can rupture anytime. And then they must be ready for follow-up. It is important to mention that for those that have carried out this controlled expectant management, we have found out that about 69% of subjects will disappear. So it's something to talk to a patient, to discuss with the patient about the possibility that the ectopic particularly is on rupture and is willing to subject herself to admission, and then of course the potential risk of rupture. It is important for her to know that in some cases the thing may resolve on its own. As part of follow-up, the patient needs to have a twice-weekly beta ACG measurement, and in the first 7 days of admission, the ACG levels will fall below 50% of the initial value. And then patient should have a weekly transvaginal ultrasound to assess the reduction inside of the ectopic pregnancy. So while on admission, while this is going on, patient may be discharged home if there is a resolution of the ectopics, or may resort to surgery, or the other use of if there's rupture. That's why the patient should be on admission under your care, so that patient can be taken care of if there's in any eventuality. Now, again, we are still talking about conservative medical. We talk about controlled expectant management. One patient under your care, observing her under your care to be sure that the steps are taken to take care of her if there's any rupture. Now, for the medical, again, for medical conservative, now the selection criteria again is almost similar to that of controlled expectant. Again, the minimal symptoms, patients should be stable hemodynamically. There should be no sign or symptoms of active bleeding or hemoperitoneum. There should be absence of fetal heart, on the ultrasound of the ectopic. And then, of course, because we are using methotrexate, you should have a baseline value of full blood counts, electrolyte plus creatinine, and liver function test. So that if there's any derangement, you will know, because you must have done the normal values before the commencement of the treatment. What are the exclusion criteria for medical? If there's any hepatic dysfunction, thrombocytopenia, a platelet less than 100,000 of blood decreases, that W said Y cycle less than 2,000. If a difficulty of unwillingness of the patient for prolonged follow-up, because the follow-up could take about 3 to 4 weeks. So patient will be cancelled from the beginning, that she need to be follow-up. So now it's not ready for such thing. then once it's done an exclusion criteria. If the ectopic mass is more than greater than 3.5 centimeter, and of course, if there is any presence of cardiac activity in the ectopic. What are the drugs that are used? The common drug that we use is methotrexate, which is an antifolate. Could be used locally, systemically, it could be locally as injected into the sac of the ectopic under ultrasound guidance. Other options of feticide include prostaglandin, potassium chloride, hyperosmolar glucose, and local methotrexate. So that's the option. Now, if you are using systemic methotrexate, again there are different regimens for administration of systemic. We could use single dose or 2 dose or fixed multi-dose regimen. Well, the common one that is usually is 15 milligram per meter squared, and is given via the intramuscular route. Again, it's important again for that you should measure the beta hCG at the beginning of the administration of the drug and measure at day 0, day 4, and day 7. We expect a 15 decrease in the hCG level from day 4 to 7. If that is not the case, then if it does not drop, then a second dose of methotrexate may be given. Or sometimes, if you think that it's not working, you may resort to surgery and then remove the ectopic. Again, it's important to emphasize that whatever, when I'm talking surgery, can be laparoscopy. Because once one have the skill and the instrument, most of this surgery can be performed laparoscopically. And therefore, even the removal of the tube or even the other treatment option can be done by laparoscopy rather than the open abdominal surgery. Now, what are the prerequisites for starting medical treatment? Because we are talking about medical treatment, you must, apart from the condition that should be met, there are other things that we should. The patient, we have mentioned that the patient should be hemodynamically stable. That patient should desire future fertility. I've said earlier that the compliance is very important for follow-up. And then, at the end of the day, patient must be ready to use contraception for only 3 months after the resolution of the ectopic. There should be no underlying medical or severe comorbidity. After we have talked about then the liver function, the kidney function should be in order, and there should be no known contraindication to methotrexate. We have to be very careful. Patient on NSAIDs, diuretics, penicillin, and tetracycline. There should be no coexisting intrauterine pregnancy, and patient is not breastfeeding. These are things we must take into account before we start the patient on methotrexate. What are some absolute contraindications of use of methotrexate? These include breastfeeding, overt or laboratory evidence of immunosuppressant, alcoholic liver disease, chronic liver disease, active lung disease, active pelvic ulcer disease, hepatic renal hematological disease, hypersensitivity to methotrexate, and some bone marrow hyperplasia. This is absolute contraindication. So the patient needs a proper evaluation before you commence them on methotrexate. Of course, what are the absolute contraindications now? If the gestational size is more than larger than 33.5 centimeter, or there's embryonic cardiac motion, or the hCG greater than 3,000 to 5,500 international units, or presence of hemoperitoneal in more than 1,000 mil. Surgical management. We have dealt with medical, conservative using medical management, and then controlled expedient management. Like I said earlier, surgical management could indicate laparoscopy or laparotomy. Laparoscopy is used because it's, on the experienced hand, of course, it's shortening time of the surgery, less postoperative pain, but of course, the equipment is expensive and you need expertise. So that is why nobody is experienced hand, and where the equipment is available is very useful. And of course, it could be useful. So the surgical management could be saphenectomy, that is, you remove the tube entirely. Saphengostomy, about you make an incision on the anti-mesenteric border and leave it open, having removed the ectopic. Saphengostomy, this is rarely performed nowadays. Saphengostomy just you open and close. No, it's rarely performed. Or sometimes I can do segmental resection, anastomosis, or fimbrial evacuation. So like I said, all these I mentioned surgical procedure can be done by laparoscopy or laparotomy. Of course, we will come to me, if you are doing laparoscopy, the patient must be hemodynamically stable. Okay, whereas in laparotomy, of course, that is necessary when patients are not stable and you need to do something fast. So, but again, like I don't for emphasis, laparoscopy will almost do the same thing as what you do for open laparotomy. Again, and then what we have done, those conservative salpingostomy, segmental resection, anastomosis, and febrile evacuation. The radical where we remove the tooth, salpingectomy, again could be done by laparoscopy or laparotomy. Again, like as important thing for us to know is that laparoscopy will be useful in patients that are hemodynamically stable. May not be useful in patients that are in shock because you need to do act rapid and very fast. So that's about the tubal ectopic pregnancy. We'll discuss about the non-tubal ectopic pregnancy, which comprise of cervical pregnancy, ovarian pregnancy, abdominal pregnancy, interstitial pregnancy, intraligamentous pregnancy, heterotopic pregnancy, and cesarean section scar ectopic pregnancy. We'll just go briefly because, like I said, most of the time as we spend on the tubal ectopic pregnancy, is the commonest of the of the ectopics. Cervical pregnancy, occurs in about 1 in 2,400 to 1 in 50,000 pregnancy. For the cervical pregnancy, what are the risk factors or what we call predisposing factors? Include previous therapeutic abortion, Asherman syndrome, previous uterine section, DS exposure, leiomyomas, and IVF. Patients who have undergone IVF procedure. Again, what are the diagnostic criteria? Again, patient will present with vaginal bleeding, sometimes with massive or torrential vaginal bleeding, or sometimes abdominal pain, very rarely because the blood may not track into the peritoneal cavity. So most of them they present with maybe amenorrhea and then vaginal bleeding that may be heavier than what we think you're normal, except in incomplete miscarriage. But when you examine, you find that the uterus is smaller than the surrounding distended cervix. Now the internal wall is closed. It's not dilated because this pregnancy is limited to the cervical one. And of course, the external wall is open earlier than the spontaneous miscarriage because since the pregnancy is the cervix, then when there is any miscarriage, of course, then it will open earlier than the intrauterine pregnancy. Well, if you do any curettage, and of course you subject to histology, there will be no placenta tissue that will be gotten out from the endometrial cavity. What are the treatment options? It could be non-surgical treatment, and surgical. Again, we have seen the central role of methotrexate that could be, so we can use systemic methotrexate or intraamniotic. Again, these are probably the patients that are not bleeding heavily. If the bleeding is severe, you need to do surgical procedure, which some of the surgical procedure we do could include dilation and curator with tamponade, angiographic embolization, where I have the expertise and the equipment. And then actually you can ligate the uterine arteries that supply the uterus, and then sometimes, you may do internal iliac artery ligation, or you may have to do hysterectomy. If all attempts to control hemorrhage fails, you may have to do hysterectomy, that will now be total hysterectomy so that the bleeding can be arrested. Ovarian pregnancy, again, is considered about 0.5 to 1% of all ectopics, and is perhaps the most common type of non-tubal pregnancy. The symptoms and signs are similar to those of tubal pregnancy, ruptured tubal pregnancy, and sometimes ruptured corpus luteum. So most of the time when you make this diagnosis is on the laparotomy or laparoscopy, because you now find that there is indeed no tubal ectopic pregnancy. So what are the treatment modality? Well, again, for ovarian cyclectomy, so you try and remove as possible the disease part of the ovary and leave the normal ovary intact. So that one ovarian cyclectomy. Sometimes treatment with methotrexate and prostaglandin injection also been reported to be useful. Now there is a criteria for diagnosis of ovarian pregnancy. I think we should be familiar with. We have to speak about criteria. There are 4 of them. So when you are laparotomy, you will now find out, rather than you are not dealing with ectopic pregnancy, you should closely look for these 4 criteria. 1, the fallopian tube on the affected side must be intact. The fetal sac must occupy the position of the ovary. 3, the ovary must be connected to the uterus by the ovarian ligament. And finally, ovarian tissue must be located in the sac wall. So these are the things I want to keep in mind, because like I said earlier, that the presentation is similar to that of ruptured tubal ectopic pregnancy. You make the diagnosis of rape pregnancy most of the time when you get on the table, but you must look for these 4 criteria so that will now maybe to confirm that indeed you are dealing with ectopic pregnancy. Abdominal pregnancy is another variety of non-tubal ectopic pregnancy, and it could be primary or secondary. Primary is that implantation of the blastocyst occurs primarily on the peritoneum or any organ on the abdominal cavity. The secondary one means that there's something that's happened before, particularly ruptured tubal ectopic pregnancy, and then traverse through the tubal wall or by one mechanism or the other, get implanted into other part of the abdominal cavity. So it's the more common of the two, and may result from tubal abortion or tubal rupture, or less commonly from implantation within the abdomen after uterine rupture. These are rare things, but like I said earlier, it is more common than the primary abdominal pregnancy. In abdominal pregnancy, incidence of congenital abnormality is high, 20 to 40%. We can understand that because there is perhaps no abdominal fluid to cushion the effect of pressure here and there. What are the clinical presentation? In the first and early second trimester, the presentation may simulate tubal ectopic pregnancy, ruptured tubal ectopic pregnancy. Because like I said, since the secondary abdominal pregnancy is more common than the primary, so patient with a rupture or subacute, if you remember subacute rupture, may come with recurrent vaginal bleeding, recurrent abdominal pain, recurrent fainting attack. In fact, what we may be dealing with may end up to be a secondary abdominal pregnancy, because that pregnancy may extrude from the tube and get implanted on any peritoneal organ or surfaces. And then, but that typical pregnancy may continue with, recurrent abdominal pain, recurrent vaginal bleeding, or recurrent fainting attack. But when it is advanced, then the diagnosis may be easier, because at that time there may be painful fetal movement. The fetal movement may be high in the abdominal, or there may be sudden cessation of fetal movement. Again, when you examine, there may be persistent abnormal lies, abdominal tenderness, and the cervix and maybe displaced. And then there may be, sometimes in the past you may use what we call test of oxytocin infusion. There may be no uterine contraction when the patient is stimulated with oxytocin. But nowadays, the presence of ultrasound, transvaginal ultrasound, abdominal ultrasound, 3D ultrasound may be useful. But of course, that is not foolproof. One may still miss it, even in spite of all the ultrasound that are available. So there are some criteria for abdominal pregnancy. Again, when eventually you now open up, what are the criteria you must look at to make sure you are dealing with abdominal pregnancy? That was primary abdominal pregnancy now. One, what we call study for criteria. The presence of normal tubes and ovary with no evidence of recent or past pregnancy. So that we are trying to look at the criteria for primary abdominal pregnancy. There should be no evidence of uteroplacental fistula, and the presence of a pregnancy relates exclusively to the peritoneal surface and early enough to eliminate the possibility of secondary implantation after primary tubal abortion. So these are criteria for the primary abdominal pregnancy, because the temptation will be, unless you make this thing clear and make it, you look closely for this at laparotomy or laparoscopy if you have the expertise, then one may think it's just secondary abdominal pregnancy because it's more common of the two. Well, the treatment of abdominal pregnancy, again, is surgical. Whenever it is diagnosed, of course, you should intervene surgically. But sometimes, if you make a diagnosis late in pregnancy, after 20, 30 weeks, and you think the fetus may survive, you should be able to admit the patient into your ward, group and customer, several units of blood, consulting your vascular surgeon, your anesthetist, and everybody is aware that you have another pregnancy on your ward, because surgical intervention may be necessary, maybe accompanied by massive hemorrhage. So everybody should be around for such. But if you did not make a diagnosis early, below 28 weeks or no, you should intervene surgically early. And then, of course, you know that you must get blood ready, several units of blood ready, check a pack cell volume, resource typing, and of course, ready for surgical surgery. Ready for surgery. Well, after open, what do you do? The placenta. Okay, the placenta may be left intact if it is implanted on organs, central like the liver, and so whereby you cannot hemostasis after removal may be difficult and could be extremely dangerous. So sometimes what you do just cut short, and then you leave it behind. Sometimes that bleeding, again, that's why I say you should involve your cardiovascular surgeon as you're going. And then the bleeding does not, so you may have to pack the uterus, the abdominal cavity, and then remove your gauze after 24 to 48 hours. Again, if you leave the placenta in situ, then you may use adjuvant methotrexate, with arterial embolization, so that to stem the hemorrhage as it occurs. So the abdominal pregnancy is something that you take lightly. It's cool. It's very. It could be bleeding, could be massive. Therefore, you should involve your everybody, the anesthetic, the cardiovascular surgeon, before you do your laparotomy. Interstitial pregnancy represents about 1% of all ectopics. Again, patients will present later than those with tubal pregnancy because of the fact that where the thing is located, there's some element of smooth muscle we can accommodate the fetus before its rupture. Well, it's often associated with uterine rupture, hence high fatalities. What are the treatment? Again, from the general treatment of grouping and cross-matching, the specific surgical treatment will be that the coronary resection by laparotomy. Sometimes you may have to do the hysterectomy if you have uncontrollable hemorrhage. Intraligamentous pregnancy is very rare too. It usually results from trophoblastic penetration of a tubal pregnancy through the serosa into the mesosalpinx, with secondary implantation between the leaves of the broad ligament. Again, can also occur if a uterine fistula develops between the endometrial cavity and retroperitoneal space. The clinical findings of intraligamental pregnancy is almost similar to that of abdominal pregnancy, and therefore surgical principles are almost similar to that of abdominal pregnancy. Ectopic pregnancy is the coexistence of ectopic pregnancy and another intrauterine pregnancy. It's very rare. In spontaneous pregnancy, it's about 1 in 30,000 pregnancy. But with advent of an increase in use of IVF and other assisted reproductive techniques, the incidence has increased. So there are high incidence with patients who undergo ovulation induction. Again, treatment is operative. In other words, you must remove the ectopic and then conserve the entire pregnancy. So it could be removed either by laparotomy or laparoscopy, depending on the expertise. And in such cases, the continuation rate of the internal pregnancy is about 70%. Well, the last of the non-tubal ectopic is cesarean section scar ectopic, which actually was recently described in 1997. It's the rarest form of ectopic pregnancy, and the incidence of cesarean delivery is about 1 in 1,800 to 1 in 2,500. It's a life-threatening condition, can cause exaggerated hemorrhage and uterine rupture. Usually, the gestational sac partially or fully implants on a cesarean section scar. Diagnosis is very difficult, and false negative diagnosis can result to major catastrophe or complication. The mechanism is not clearly understood, but some people think that it's just invasion of the blastocysts through the microscopic tract that develops from the trauma of an earlier cesarean section. What are the risk factors The risk factors include previous cesarean section, myomectomy, adenomyosis, previous dilation and curettage, manual removal of placenta, manual removal of placenta. Now, what the presentation could be, painless vaginal bleeding is the most common. It could be abdominal, there could be abdominal pain. Patient could present hypovolemic shock following uterine rupture. And sometimes it's not uncommon to diagnose cesarean section scar ectopic during or after an attempted surgical evacuation of mixed miscarriage. So, like I said, it's a killer because most of the time the diagnosis is mixed. Well, there are two types of scar ectopic. One, there is what we call endogenic or type 1. This one does mean that the vaginal sac implant on the scar and grows toward the cervix or cervical ischemic or uterine cavity. So that's what we call endogenic. In other words, the sac grows towards the uterine cavity or cervical the cervix. The type 2 or exogenic is the implanted ectopic grows towards the bladder. So you can see that the procedure will depend on the type of ectopic. Is it endogenic or is it exogenic? If it's endogenic, typically may come with bleeding, torrential bleeding. If it's exogenic, well, it traverses the bladder, the uterus. It also may come with abdominal pain and then a shock. What are the diagnosis? The diagnostic tools? Well, I think the important thing for us is for first and foremost to always heighten our index of suspicion. In any patient with cesarean section, myomectomy, or dilation and curettage, present early in pregnancy with vaginal bleeding, abdominal pain. It is good to know that it is important to always put in mind rupture tuber ectopic pregnancy. But anybody that comes with uterine scar, either myomectomy or cesarean section, or even curettage, then we must always think of the possibility of cesarean section ectopic. So when you do your ultrasound, what do you find? You find that the uterus is empty uterine cavity, empty and closed cervical canal, because you already have said that if it's cervical pregnancy, of course, the external also will be open. The placenta or the gestational sac is embedded within the scar, so you need that, the person doing this scan should be experienced to know where the scar is, and the yolk sac or embryo and cardiac may or may not be seen. So the diagnosis is mainly ultrasound apart from clinical diagnosis. Well, a combination of transabdominal and transvaginal scanner has high accuracy rate in the diagnosis of cesarean section scar. So you may have to do a combined transvaginal and transabdominal scan, which will help in the diagnosis of cesarean section scar ectopic. What are the treatment options? Again, for all patients, before you treat, you must give options. Expedient management is rarely used, of course, you have said that it's very catastrophic, so there's no place after for expedient management. Could use medical use of methotrexate. We have seen methotrexate occupy a central role in many ectopics, either rupture, about tuber rupture, or rupture tuber ectopic, and so on and so forth. But of course, you can do local injection under ultrasound guidance, or local injection and embolization. So you can inject methotrexate, you can inject other embryosides, or you can do intra-artery chemoembolization. Surgical procedure for cesarean section could include suction curettage under ultrasound guidance, followed by balloon tamponade, because of course, if you don't do that, you must tamponade the effect of your curettage so that bleeding will stop. And then you can do uterine artery embolization if you have the expertise. You can do stereoscopic resection. Again, these are very highly skilled procedure. And of course, if everything fails, you should go on to do hysterectomy. I think that concludes our lecture on ectopic pregnancy. And so far, we've discussed what exactly is ectopic pregnancy. We have discussed what are the risk factors of ectopic pregnancy. We have discussed the pathology of ectopic pregnancy. We have discussed about the types of ectopic pregnancy, tuber ectopic pregnancy, not tuber ectopic pregnancy. For the tuber ectopic pregnancy, we have discussed the rupture tuber ectopic pregnancy. We have discussed the rupture tuber ectopic pregnancy, and there are different treatment modalities, which could be from conservative. In other words, we have to preserve the tube, and the preservation of the tube could be either the medical using drugs or surgical using laparoscopy, depending on your expertise on the availability of the equipment. And of course, we now went on to discuss about the non-tubal ectopics, which could be cervical ectopics, ovarian ectopics, abdominal pregnancy, cesarean section ectopic, intraligamentary toss ectopics, and we have done about the various treatment options that are available. So I hope we should be able to manage a case of ectopic pregnancy clinically so that we can, because we know that ectopic pregnancy is actually some morbidity and mortality. Therefore, we can continue to save our mother from unavoidable maternal death. Thank you for listening.